Good morning, everyone. We're going to go ahead and get started. Thank you so much for being here. Welcome, everyone, to the Coalition of Orange County Community Health Centers Coffee Connections event. It's wonderful to have you all here today for our second in-person Coffee Connections event, but it's the first of 2025. For those of you that joined us last December, that was actually our first in-person Coffee Connections event. We have been holding these quarterly events since the pandemic began because we want to create a space where we're able to share information with our members, with our partners, with our friends that is relevant given the current political landscape then and now. I am honored again today to host the most important dialogue on the first 100 days, navigating healthcare priorities and opportunities in a new administration. This is critically important for us to be together to discuss what's happening right in our country, what's happening in our communities, how that's going to impact us at every different level. And I am very excited to be able to do that again amongst friends, amongst key partners, and individuals that are really taking what's happening in such a serious way that we have vowed to make sure that whatever happens, we are still here to make sure that we are addressing and mitigating whatever changes come our way, but also that if we have to rebuild, we will. So I've said all that and I haven't told you who I am, and I apologize for that. So my name is Isabel Becerra. I am the President and CEO for the Coalition of Orange County Community Health Centers, in case you all have not come in contact with us before, but I highly doubt that. Today, we represent 20 community health centers in the county and one community-based organization. We collectively provide care to over 300,000 individuals and about 1 million visits a year. And there are over 80, again, locations throughout the county, from as far north as La Habra to as far south, again, as San Clemente. And before we begin, I'd like to take a moment to recognize and thank the many individuals and organizations who made today's event possible. Our speakers, thank you so much for lending your time, expertise, and critical insight into today's conversation. Our member health centers and community partners, your dedication to serving our communities continues to be the foundation of our work. Our students and emerging leaders that are in the room, we are especially excited to have you here today because you're our future. Your curiosity, your passion, and commitment to learning are what will drive the future of healthcare. Thank you for joining us and for bringing fresh perspectives to these important discussions. And then our attendees, thank you to each and every one of you for being here today. As I've stated before, your commitment to healthcare equity and for engaging in this critical time at such a pivotal time is really what's going to make all of this work going forward. Lastly, I want to thank the elected officials with us here today, including Kim Carr, Senior District Representative for Senator Catherine Blakespear's office in the 30th District. Thank you. And Janelle Atienza from the Office of Assemblywoman Diane Dixon from the 72nd District. Janelle, I know I saw you here earlier and you wanted to come up here for a second. Janelle has a certificate of recognition that she wants to present to the coalition. I'm going to give her the floor.
Hi, everybody. My name is Janelle Atienza with Assemblymember Dixon's office, and thank you guys for all that you do for healthcare centers in Orange County and for prioritizing member education, collaboration, and quality care.
Thank you. So our Coffee Connections events, again, are designed to be more than just conversations. They are a space where we come together as a community to explore critical health topics and exchange ideas and inspire action. And we encourage you to network, as I saw many of you do before during our breakfast session. It's really intended for you to come together and either make new connections, make new friends, or re-engage with old friends. And I see a lot of friends in the room, so appreciate you all again so much. As we step into a new administration, the first 100 days, as you all know, will set the stage for healthcare priorities, funding, and policy shifts that will impact our patients, our organizations, and our communities for the foreseeable future. Today's discussion will help us navigate these changes together ensuring that we remain proactive, collaborative, and prepared to advocate for the needs of those we serve. To give you a sense of how today will flow, we will begin with an opening session where we're going to have the stage set, if you will, by Dr. Dylan Roby, who will provide us with some context for our conversation. Next, we'll have an amazing expert panel of individuals that will engage or lead us in an interactive session and discussion for what will come as we navigate these sessions or these changes that we're all facing. After that, we will have a Q&A session and then next steps. This structure allows us first for our speakers to set the stage and allow us to continue to, again, navigate what's happened thus far. And with that, I see Dr. Roby here, and I want to help you all, or have you help me join Dr. Roby to the stage. Thank you. Thank you.
Can everyone hear me okay? Yes? Okay. Hi, everyone. It's nice to see you all. If you can believe it, it's only been 40 days into this administration. It seems like the world has turned upside down to an extent. I had to go in the corner and check my phone to make sure I didn't miss anything that might have happened this morning. Apparently, we're very close to a deal with Ukraine that will probably result in a Trump Tower being built very soon there. But like every day, something is new. And I think this is very atypical for a typical 100 days of an administration, even the first Trump administration, where we saw lots of planning and activity, but not as much disruption. So I'm Dylan Roby. I'm a professor at UC Irvine in the Department of Health, Society, and Behavior, or the newest School of Public Health in the UC system, the UN School of Public Health. Great. So I'm here to talk a little bit about kind of health policy updates and what's going on in Capitol Hill, but also in federal agencies and how it might kind of trickle down to local and state policy issues. So today I'm going to talk mostly about kind of what the Trump administration has been doing, what Republican members of Congress have been doing related to the healthcare system, but also kind of the operations of the federal government and what the likely impact will be on the healthcare safety net in California and beyond. So, as I mentioned before, this is kind of an atypical world we're living in right now from a federal government perspective. Typically, in the first 100 days, you don't see lots of action from the White House, except kind of setting policy priorities, meeting with Congress, releasing their budget proposal, usually in between February and April of the first year they're in office. And that budget proposal typically aligns with the agencies that are cabinet level agencies, the 19 cabinet level agencies, including Health and Human Services in a given year. And typically the president will kind of defer to the secretary of each of those agencies, who is coming on board and usually ramping up by hiring people, bringing in political appointees, and then planning steps forward for that agency. So yes, we have seen in the past a flurry of executive orders to overturn specific rules that were made by a previous president. Like every year we see every administration, the Mexico City policy around federal dollars going to NGOs in other countries around family planning. Usually a Republican will revoke the executive order, a Democrat will reinstate the executive order. And we see that dance every 4 years or every 8 years. But this time was kind of atypical in that the president issued many executive orders in the first week of taking office that have kind of been developed in the background. And at the same time, we have this new entity that has come up that isn't a federal office, and isn't part of any specific agency. So it's the Department of Government Efficiency, administrated by an unknown person, but kind of spearheaded by Elon Musk. And the DOGE office, it actually does have some level of federal standing in a way, because what happened on the first day of the Trump administration was he issued an executive order creating DOGE in the executive office of the president. So you may have recalled, many years ago under President Clinton, we had like a drug czar, and we always have these people who are not appointed in an agency, but they are appointed in the White House, and typically it's in the executive office of the president. The law is pretty clear about the role of the executive office of the president in not running executive agencies. They are supposed to provide guidance and coordination across all of the 19 cabinet level executive agencies. However, the way this has been working currently is that the DOGE team has basically been put on detail to different federal agencies for temporary periods of time. So the reason you're seeing them able to go in, access data systems, terminate certain employees, issue proclamations about early retirements or reductions in workforce, because they're basically, even though they're sitting in the executive office of the president, they are then assigned on detail for like 2 weeks at Health and Human Services and 2 weeks at USAID. So they become employees of that entity. They go in and have access to systems and the building and leadership, and then they are pulled out and put on detail somewhere else. So technically, it's like a legal activity because they're being put on detail at these different executive agencies. Typically, though, somebody like that who's dealing with government efficiency and trying to coordinate across all agencies would be sitting in the executive office of the president and talking to all of the different agency secretaries about their needs and about how the priorities of the administration should guide personnel decisions. But instead, it's kind of all going on at the White House level and using this kind of detail to implement changes. So this has led to some court challenges and temporary restraining orders in several cases. In one decision, even though it did not restrict the use of DOGE to have make hiring and firing decisions, it did kind of question the legitimacy of DOGE as an entity. And the decision is a slippery slope, I think, for President Trump and Elon Musk, in that it basically said DOGE is acting as an agency, and so therefore, maybe they're subject to FOIA requests. Maybe they have to deal with due process from a federal agency standpoint, since they're sending people in on detail and they seem to be acting as an agency. So that'll be an interesting thing to play out. So right now, federal workers are fearful, demoralized. Many do not know if they're going to have a job next week. And there are lots of things being done that border on illegality that are being tested in the courts. So for example, a decision came out yesterday from a federal court that said the Office of Personnel Management, which we always call the human resources of the federal government, doesn't actually have the authority to fire people directly, because several years ago, OPM handed over the authority to do staffing decisions and do force reductions, which is what we're seeing now, at the agency level. So each agency has their own HR department that's supposed to carry those out. And so the 5 bullet points email that you saw come out, the fork in the road email that came out about people retiring or resigning early, all of those have been coming from Office of Personnel Management, not from the agency heads directly. So there's some question about whether the agency should be doing these things or if OPM should be doing these things. And the federal court said OPM shouldn't be doing them, so there's a pause on those hirings, and there's a view that they shouldn't have happened. But you could then see those firings reinstated or those employments reinstated, and then the agency would have to carry out a process. But the agency policy around force reduction is a more detailed and drawn out one. So yes, it is possible for federal employees to get laid off or get terminated. But if there's a large scale force reduction, as we're seeing now, that typically has to go through due process that takes several months, not what we're seeing from OPM at this point. So there's a lot of misunderstanding about what the role of OPM is, what the role of the agency is, but it's this issue about the White House challenging their kind of challenging current custom and rule about how federal agencies work and seeing if the courts push back. My understanding in DC is that a lot of the agency secretaries are kind of unsettled around their current role, and they feel that Elon Musk's role and the White House's role is kind of outsized versus what we'd see in the past. So I think as this continues, we will see some tension around the secretaries that have been appointed to serve the different agencies and their views of their own power and autonomy versus having to work for Elon Musk or the Trump White House. So I think we'll see some conflict there as well. So it's a big mess on the federal side. And at the same time, we have to consider that the federal agencies don't really have the power to change policy to a certain extent, and that the programs and spending that we see is still the role of Congress. So last week, we saw the House take action on a budget resolution. The Senate has their own competing budget resolution. So there's a president's budget proposal, and there's also the House budget resolution. And it includes tax cuts that will be paid for partially by cuts to safety net programs like Medicaid and SNAP. And I'll detail the process in a second. We also see issues around the potential threat of immigration enforcement. And, last week, or this week, I'm losing track of the 40 days. This week, we saw a call by the Trump administration to have a registry for all undocumented immigrants age 14 and above that includes their fingerprints. So we will probably see many of these things challenged in court as well, but also lots of uncertainty introduced into communities that, where the Trump administration could be overstepping their bounds as it relates to legislation and administrative regulations. So I apologize if I go into professor mode on the budget side, because Mr. Rodriguez did not teach this to me in US government at Riverside Poly High in junior year. But over the years, I've learned a lot about the budget process and the actual role of the legislature in guiding our government. So this week, we saw a budget resolution that passed the House on a very slim majority, 217 to 215. And President Trump has signaled that he supports the House version of the budget resolution because it represents a really large bill that could be passed through a process called budget reconciliation. So remember, the budget resolution is the plan for Congress to create a budget. It is not binding. So, but it does it gives us a sense of the priorities and how they will be paid for. So we won't see the discretionary budget from the White House until April. So if you think about our federal budget, we have discretionary programs and we have mandatory programs. Discretionary programs are things like community health centers, going through Health Resources and Service Administration, CDC's budget, NIH's budget. All those federal offices that we know and love are running through the discretionary budget. The mandatory budget is not subject to negotiation each year because it's automatically appropriated and delivered, but that discretionary budget includes Medicare, Medicaid, and Social Security. That being said, if you have a budget bill, you are allowed to take from those mandatory programs to pay for discretionary changes. So if you want to run a budget reconciliation package through Congress that increases revenue from changes to Medicaid and Medicare to pay for other things that you want to spend money on, that is legal and it can go through the legislative process. So we will see a discretionary budget from the White House come out in April probably, but it'll probably match the budget resolution that we're seeing coming out of the House right now. So President Trump has endorsed this resolution. The Senate has a different version that Lindsey Graham has been pushing as the Budget Committee chair in the Senate, but it splits things up. It has a border security and defense bill first, and then it says we'll deal with tax cuts and Medicaid changes later. But Republicans don't really like that idea, and Trump has said he wants one big, beautiful bill, as he calls it. So right now, what we're seeing in the budget resolution is about $4.5 trillion in spending that is then offset by about $2 trillion in cuts to existing programs. 1 trillion of those cuts are destined to come out of House Energy and Commerce and Agriculture. House Energy and Commerce, 80% of what they have jurisdiction over is Medicaid. So they were given instructions in this budget resolution to cut $880 billion from their 10-year budget. And everybody says, well, there's not lots of things in the Energy and Commerce budget that can be cut besides Medicaid. There's only about $260 billion over 10 years in the House Energy and Commerce budget that's not Medicaid. So if it's $880 billion coming out of the committee, it has to come out of Medicaid. Agriculture, they're required to cut $200 billion in this budget resolution, and they have jurisdiction over SNAP. So half of the budget cuts that this budget resolution relies on will come out of SNAP and Medicaid or committees that deal with SNAP and Medicaid. So you see people like Steve Scalise on the Republican side who held up the budget and said, there's no mention of Medicaid in this bill. That is technically true, yes. But it says cut $880 billion from energy and commerce, and energy and commerce is the Medicaid committee. Like that's what they are known for, and that's what they control. There's also proposals, if you look at the Republican caucus reports and also Project 2025, to remove Affordable Care Act subsidies for people earning over 4 times poverty from the American Rescue Plan Act. Those expire December 31st, 2025, and without renewing, they would go away. The existing ACA subsidies would stay in place. However, that's dangerous to red states, right, where Medicaid expansion didn't always occur, and so there are a lot more people getting enhanced subsidies from the American Rescue Plan Act money in those states. But we'll also see these efforts to like pay for tax cuts with changes to Medicare and Medicaid potentially. And there's, if you want to read all the details, you can find, if you Google like leaked memo Republican plans, you'll find the list, a laundry list of all the different things that Republicans could do to cut Medicaid and what the plans might be. So the reason why it's going through this budget process is because the Senate only has a 53-47 Republican majority, and the House has a slim Republican majority. And so there's not 60 votes in the Senate to pass a bill through regular order, like through a regular piece of legislation. So every single policy issue that Republicans want to change this year will have to go through budget reconciliation because there's not Democratic support for making those changes. Now, the catch is, if something is in a budget reconciliation bill, it has to be money related, and its primary goal has to be saving or collecting revenue and cutting costs. It can't be a policy issue. And there's a Senate parliamentarian, Elizabeth McDonough, who, when a bill like this is being considered, sits down with the Democratic Party and the Republican Party leadership and goes through each thing, and Democrats will challenge each item. So they will say, well, we don't think this is a spending issue, this is a policy issue. And McDonough will then say, I agree, this is a policy issue. It is subject to a 60-vote majority to get it in the bill. And so Republicans could then abandon it. And we saw that in the efforts to repeal and replace the ACA in 2016 and 17, where the Republican budget reconciliation package included getting rid of pre-existing condition protections. It included changes to how insurance markets work. And Elizabeth McDonough rejected those changes and said they have to go to a 60-vote majority. Republicans were unable to get that 60-vote majority, and so they ended up with a pure like spending and cutting bill that was a watered-down version of what they wanted, which is why you saw John McCain and others kind of vote no on the bill and make it all fall apart. So that could happen again this year, and it's unclear as to what reforms Republicans will use to pay for the different changes to Medicare and Medicaid. Now, to give you a sense, one of the two main issues that have come up in the past around Medicare and Medicaid to get to this $880 billion in savings are per capita caps, which would get rid of the current kind of matching-based formula and move to capping Medicaid spending at a certain historical level for each state, and then cutting the federal matching rate, so the FMAP rates, the federal medical assistance percentage. Right now in California, we get 90 cents on the dollar for every Medicaid enrollee who's in the childless adult ACA population. We get 50 cents on the dollar for children, disabled, aged, blind, and some parents who are eligible in Medicaid prior to 2014. So we have these two populations that get different matching rates. We also have a different matching rate for children's health insurance program. So all of those generate about California spending 35 cents on the dollar in Medicaid out of state funds and 65 cents out of federal funds. If the per capita caps went into place over 10 years, you would probably see California lose about $530 billion in revenue that's coming from the federal government that they would have to fill in the gap for. So it's either come up with $75 billion over a 10-year period, or cut Medicaid enrollment. So would you see us dropping our Medicaid eligibility? Would we have to get rid of the undocumented expansion? Would we cut benefits? Would we get rid of adult dental again, as we did in the last economic downturn? All those would be choices. And so the state would then have to decide, do we figure out a way to come up with $75 billion over 10 years, or do we decrease Medicaid enrollment? And if we decrease Medicaid enrollment, it'll likely be 1 in 5 people would lose their Medicaid coverage. And a lot of those people would likely be in the ACA expansion population rather than the mandatory populations, child, disabled, blind, patients. So there's a very good Kaiser Family Foundation report that kind of details these changes and gives a California estimate, which is what these tables come from. If they did per capita caps and decided to change the matching rate for each state and go down to 50 cents on the dollar for everybody, so we would lose our 90 cents on the dollar in Medicaid for the ACA population. It could go down to 50 cents on the dollar, and then we'd have to plug a much larger gap, $175 billion over 10 years, and it would likely result in a 44% decrease in Medicaid enrollment statewide. So those are some pretty severe outcomes, right? Where a lot of the progress we made in terms of getting people insurance coverage and expanding Medicaid will be cut in half over a 10-year period because of the either a new matching formula or the use of per capita caps or both, which is kind of a worst case scenario. That being said, these are scary cuts for Republican states as well, especially those that expanded Medicaid. So Mike Johnson has said that they're not interested in doing per capita caps or federal medical assistance percentage changes in this budget bill, because I think he got a lot of pushback from Republican members in states that expanded Medicaid who would have constituents that would lose coverage. So, you know, if you have people like Young Kim and Ken Calvert in the area who would lose out from their constituents would lose insurance coverage, and I think Corona, Yorba Linda, Ken Calvert's district probably is in the top 10 of losses. David Valadau's district is also very high on that in the Central Valley, where there are lots of constituents who would lose coverage, lose insurance due to these changes. So Mike Johnson said last week, well, we are going to figure out a way to pay for that $880 billion through work requirements and provider tax changes, which California relies on quite heavily, and also combating waste, fraud, and abuse. So we will see what the actual budget reconciliation package says in the final, kind of the final draft, which we'll likely see this April to May. But to me, it seems that you can't find $880 billion in Medicaid over 10 years if you don't tackle the medical assistance percentage or change how we're doing budgeting. Work requirements only save you about $120 billion, and provider taxes only save about $175 billion nationwide. You still need another $500 billion to cut from. So you may see Republicans on the more moderate side say, you know, I'm unwilling to vote for a bill that completely undermines Medicaid. My constituents have now become reliant on Medicaid, and I don't want to get rid of it and cost a bunch of people insurance. And they would then draw a line in the sand around matching percentage and per capita caps, and you see more kind of tinkering around how things are financed. But it's very likely that work requirements will end up in that budget reconciliation bill. Then you end up in a world where the parliamentarian has to rule on whether those work requirements are a policy issue or a budget issue. And I can almost guarantee she will say it's a policy issue. You can't just put a work requirement that saves money and say that the main goal was to save money and therefore it's a budget issue. She will say, well, that's a policy change. And so if work requirements go away in the final hour and President Trump is pushing for this bill to be passed so the tax cuts can be extended, and the parliamentarian strips out the work requirement or requires a 60-vote majority, then you go back to the really draconian cuts of the per capita cap and the matching rate. And in that hustle bustle of trying to get things done, who knows what we will end up with. So I think it's really important to ensure that local members know what's at stake when these big changes are made to Medicaid. And this budget resolution gives instructions to extract quite a bit of savings out of the Medicaid program. And that can be a very dangerous thing for the safety net, but also for people's insurance coverage overall. We're also seeing efforts around immigration enforcement, of course, and the concern that they will be going to college campuses, federal qualified health centers, other areas to try to pursue folks they think are not lawfully present. And so I think we will likely see the public charge rule come back, which kind of chilled people signing up for Medicaid and other programs they were eligible for, even if they had appropriate legal status. So I'm very concerned about that as well. At the same time, we are seeing agencies using executive power to limit spending on funds that are already appropriated by Congress. There's another court case related to the USAID that relates to whether federal agencies have to follow through on the promises made by Congress in appropriating dollars. And so we saw federal agencies decide we're no longer going to pay invoices for work already done or work already encumbered. And instead, a judge issued temporarily that the federal government had to pay those invoices. Then Justice Roberts stepped in as the DC District Court representing the Supreme Court and delayed that decision. So we'll see what Justice Roberts does in the next couple of days around whether promises made by Congress could actually be overridden by the executive branch. And that's a very dangerous precedent to set, right? Because then you end up with a budget that includes community health center money and money for disproportionate share hospitals and all of the programs that we are used to seeing in the discretionary budget. And if the administration can unilaterally decide not to pay those invoices, that's a very dangerous thing. At the same time, you are seeing confusion and barriers to drawing down funds now. So those of you in the community health center world have probably heard about community health centers not being able to access their grant money through HRSA because the administration is trying to keep invoices from being paid. And that, even if it doesn't hold up, even if it's temporary, that means cash flow problems for community health centers that many of our community rely on. So it's a really, that legal case will be really important in figuring out like where the federal government's federal agencies' power resides versus what Congress appropriates. And I think if that decision still lands on the side of Congress controls the purse strings of the federal budget, that will be a positive development, simply because then at least you can rely on our representative government in the US to drive policy decisions and spending decisions. But if you have precedent set where executive agencies can just decide not to listen to the federal budget and therefore undermine the power of Congress, that can be a very dangerous position to be in. So I'm happy to stop there. I think we're going to have a great panel discussion where we'll do any question and answer, but I appreciate your time, and I hope it's not too dismaying, but I think hopefully it's an area where you can understand a little bit better of the chaos that is occurring. Don't feel bad if it's not completely understood, because nobody knows what's going on at this point, and you really have to kind of use your own lens to figure out where you might be effective and how to cope with all of these changes. So thank you.
So I want to break it down for you just a little bit for the local level. I think it's important for you all to understand what that impact looks like for us in Orange County. But Dr. Roby's insight, again, gives us a great foundation as we look at the two major budget processes that Congress is dealing with, as you all heard earlier, right? And the first one is tied to the March 14th deadline, and that's going to determine the 330 funding that a lot of our community health centers rely on. And I know we're all watching that very closely because it will impact community health center funding, telehealth flexibilities, and other essential health programs that many of our organizations rely on. This would cause significant disruption in care. I think it would cause, and I've said this before, a dismantling of many of the systems and infrastructure and programs that it's taken a lot of us decades to build. I think a lot of us in this room have spent a lot of our careers building the system and infrastructure that we have today, and it's just very disheartening that in a matter of days, if you will, things are going to be just, again, dismantled. So I know I'm preaching to the choir in terms of why this is such an important conversation for us to have today in this room. And again, I'm very thankful that we're here to at least try and break this down in piecemeal sections that we understand, and hopefully we'll come out of this with some action items. The second area that's impacting the budget is the budget reconciliation process that Dr. Roby just described in great detail. This, again, could force significant mandatory spending cuts to Medicaid, even though it doesn't say so. I love the fact that we were able to dive into which committee oversees it, what the probabilities are of this funding, this $880 billion that they're being asked to find. Where is it going to come from? We know that we're going to get hit significantly. And so what does that mean for Orange County? It means that over 100,000 individuals in our county could be impacted because that's who our local health plan represents, right, at CalOptima Health. These are members that depend on the coverage, on all of the expansion of CalAIM. A lot of you are CalAIM ECM providers, community health worker benefit recipients or program participants, recipients of the health care for the homeless funding. There's a lot of social determinants of health that at the health plan level we've been able to deploy and implement because of the richness of the Medicaid program that we've established here in this state. And so again, in our county, 1 in 3 Orange County residents are covered by Medicaid, and 1 in 5 nationally. I don't think I need to reiterate what these cuts would demonstrate, to our community moving forward. And again, hospitals, clinics, and other nonprofits would face significant shortages. I think that we can. I'm going to go right into, first of all, thanking Dr. Roby for setting the stage, right, and helping us ground ourselves. I think that we want to make sure that we all understand that these aren't just numbers, but they represent real individuals in our community. So for Orange County's community health centers, hospitals, public health agencies, nonprofit partners, these really aren't just abstract policy debates. They are real immediate challenges that could affect access, not just access to care, but workforce stability and the ability to serve or deliver the services where they're needed the most. And we've already had a glimpse of what that initial 30 days of his administration looks like, but there's still a lot of uncertainty. I love the fact that Dr. Roby ended with that, indicating that a lot of us don't have the answers to what's coming down the pike for our organizations. But what folks want to know is that we're watching it. We are trying to analyze it as quickly as possible. We want to make sure that you understand that we are working with our local, state, and federal partners to try and exchange information as best as we can, looking at examples from the field in terms of what folks know, that there's a lot of not misinformation, well, maybe misinformation, but there's a lot of information coming from various different sources that we need to make sure that we're gleaning, that we're identifying them, and that we're looking at, again, at trusted sources to ensure that we understand what that particular impact is going to be. And with that, I know that we want to make sure that we engage in a conversation with our partners, with our keynote experts that we have here on the day in our presence today. And we want to engage in that conversation so that we can further explore what, from the local county healthcare agency perspective or a statewide foundation like the California Endowment, what are we thinking collectively about what we can do to protect, again, those critical programs, those critical infrastructures and critical systems that we know are at risk? Feedback. We really rely on the feedback for these types of events. And at the end of today's event, we'll have a short survey accessible via a QR code. Please make sure that you share your thoughts with us. Your input really helps us improve our future Coffee Connection sessions. And with that, I see the furniture is already set up. So I'm going to ask Brenda Solorzano from California Endowment, Dr. Roby, and Dr. Shate, please come and join me on stage.
Good morning, everyone. I am Brenda Solorzano, the president and CEO of the California Endowment, which is one of the state's largest healthcare foundations.
So I'm Dylan Roby, and you all know who I am at this point. I'm a professor at UC Irvine.
Thank you, Dr. Roby.
Good morning, everyone. Alma Sheikh, Dr. Sheikh from the Healthcare Agency. I have a background as a trauma and critical care surgeon, working in many of the hospitals locally and out of our county as well. My current role, I am the Deputy Health Officer for the Healthcare Agency. I like to say I'm a jack of a lot of trades, perhaps master of none, but what I really do is I oversee a lot of the population health issues, projects, ideas, thoughts that go on at the Healthcare Agency.
Thank you for those introductions. I just want to get right into the conversation, right? So I have a question for both Brenda and for Dr. Sheikh. So for Dr. Sheikh first, How is the Orange County Healthcare Agency preparing to navigate this unpredictability, right, that we're living in? And what strategies are you prioritizing to ensure that stability and support for the communities and during the ongoing uncertainty?
Loaded question, Isabel.
Yes.
A loaded
Sorry
question.
about that.
No, that's okay. It's certainly a question that is at the top of the mind of I think, frankly, everyone, but absolutely within the healthcare agency. Dr. Roby, I think you laid out just really an excellent summary of where we're at. The key being unpredictability. The key being, constant, fluctuant, changing. You checked your phone before you came on stage. I checked my phone before I got on stage to make sure nothing changed in those 15 minutes that you were speaking that I wouldn't necessarily have to address. So to your question, Isabel, how is the healthcare agency preparing? As best as we can, but I think that to really point out what it is we're doing, the first thing would be to continuously stay informed as to what is going on, because as you all know, it's changing constantly, rapidly. Nothing has been done necessarily for with assuredness. Nothing has been done for certainty. There has not been anything that has come out and said, absolutely, this needs to be done, cut, whatnot. But we all know, based on Dr. Roby's presentation, what we're seeing in the news, that cuts are coming, that something is coming. So what are we doing at the healthcare agency? We're preparing, we're informing, we're developing, those relationships, we're strategizing, we're collaborating, we're connecting with the coalition of one of many organizations. Because when you look at funding for public health as a whole, just public health is in a big picture, how is public health funded? It's through multiple arenas. Certainly the largest of which will be federal and state funds. We know that. That's the largest element that funds many of our public health programs. But you also look at local source of those fundings. You also look at how else can you supplement the work that is being done outside of just monetary dollars. It's those collaborative relationships that are built. It's the strategies that you develop. It's the networking. It's about building infrastructure. It's about assuring access to care. It's about using evidence-based data to direct what you do have to the programs that you're able to continue to keep going for that population that needs it. And with the input of the community, because I think that's the key. And Isabel, I know the healthcare agency and the coalition work very closely together, and you sit on our collaborative health improvement plan groups, the various groups and iterations that have been created, but our entire population health strategy is built around making sure that we hear the community's input to assure that your voice is heard and that we can take that back up there. I'd like to say, I think perhaps I was second on your list from the healthcare agency to be here to come and speak, because I think it was Dr. Chinseo Kwong, our health officer, who I am sitting in place of. And the reason she's not here is because she's in Washington, D.C., advocating, informing, and educating as to what it is that is needed here. So long answer, but that's a lot of what the healthcare agency is doing to make sure that we are prepared for whatever that final word will be when it comes.
Thank you, Dr. Sheikh. Brenda, same question.
Same question, but different answer, because in philanthropy, the perspective is a little different than being in a healthcare agency. For philanthropy, these are unprecedented times. Because we're looking at not only challenges around funding for our nonprofit colleagues, we're also looking at attacks around how we do our work, how we talk about our work. Nonprofit partners are afraid from a legal perspective, not just a funding perspective. There's a lot of questions around how we move forward and how we operate. So now in philanthropy, you're no longer just a funding partner. You're thinking about what other resources are we in a position to provide to nonprofits. So that may be, how do we think about building a legal advocacy strategy and legal capacity of our nonprofit grantees? How do we think about becoming a source of information given how rapidly everything is continuously changing? And also a little bit about how do we use our platform, because we have, as philanthropy, an opportunity to say and do the things that sometimes may be a little bit scarier for nonprofits and service providers to be able to say and do. The other element that is happening in this environment is that philanthropy itself is also potentially under attack. Last night, the Chronicle of Philanthropy came out with a list of the foundations that will be subject to investigation. And the challenges that that creates is that if any foundation is subject to investigation, the fear is that our assets will be frozen. And that has a direct implication for all of our grantee partners. So as you can see, it's a very complicated environment that we are facing. But we're thinking about how do we handle all of these different issues that we're facing? How do we support our grantee partners in this particular moment? And how do we think outside the box of the kinds of things that foundations can be doing? The other thing I want to share is that this is a moment for advocacy. This is a moment that we in the philanthropic space need to say, we're not just doing charitable work. We're not just doing direct services. We have to think about how do we build the capacity for communities like yourselves to advocate? How do we build the people power to begin to raise the issues that are going to happen if all the things that Dr. Roby said are going to be coming down the pike? How is that going to play out in our communities among families? How do we elevate those stories so that folks understand that this is going to have real significant impact in population health in our communities? So it's very complex, Isabel. And I'm looking forward to further conversation and ideas from all of you of how philanthropy can help you in this particular moment.
Thank you for that response. As I listen to both of your responses, I think about what we're doing at the coalition, right? What we did initially when the first executive order came out, and it was again about trying to understand it, share the information, try and make sure that we make sense out of what it could mean specifically to your particular health center. But the first thing we thought of was advocacy. So we went to our National Association of Community Health Centers Policy and Issues Forum. A whole group of us went. Some of the health centers went. Because we know we can speak with our congressmen and women here at the local district, but it matters when you show up in force with all of your peers from around the country. And I know that Dr. CK is up there doing that now, Dr. Lee, from one of our community health centers. So advocacy is important because I think at the end of the day, if we happen to be in a position where we have funding cuts so significant that we lose the base, then we start back where we started, right? Back in the civil rights movement. That's how it got started, based on advocacy and coming together and joining forces, better understanding, what we're doing. And so, Brenda, I want to ask you a follow-up question, right? It sounds like you're open to hearing input and receiving input in terms of how philanthropy can help. Are there discussions among your peers in the state to maybe collectively join forces to support some of that advocacy? Because I know that a lot of our community-based organizations probably want to partake in that advocacy, either at the local, state, or federal level, but don't have the resources or the training or the wherewithal. So what opportunities, right, have you all been thinking about collectively?
Well, I can tell you that the foundations that work in the health space in California have been meeting regularly. Ahead of the administration coming in and since the administration has taken over. And I think like a lot of us, we've been surprised at the speed at which this administration has been moving. And so while we had been having conversations, I don't think we were ready, to be quite honest, for what we are seeing. We have been having conversations about what are the things that collectively we need to be doing. So one of the first things we did is let's map out what are we all funding and where are the gaps. And so we've begun to identify that. And I think advocacy is one of those areas. A couple of other areas that have come up that we have been thinking about is elevating the story of the impact that these kinds of cuts will have. And we've identified specific communities in California that will be disproportionately affected. Now, everybody in California will have an impact, but there are communities that are going to be even more affected just because the percentage of people that live in those communities that are benefiting from many of the programs that are on the chopping block are going to be affected. So we're developing campaigns, PR campaigns that allow us to raise the issues in those communities and really target the key decision makers in those communities, congressional representatives in particular, around what is the impact that's going to happen in their communities so that they understand that when they vote for things like this, it has direct impact for the communities that they are representing. There's also been an understanding that from a legal perspective, we need to build legal infrastructure, not only by funding those organizations that are filing the lawsuits that are getting us, some pause in what's happening, but more importantly, building the capacity of our nonprofit grantees to build their own ability to access resources that will help them answer the many questions that I'm sure many of you have about how to deal with the current environment. There's also a need to really think about how do we educate the public about what this means. We had an interesting conversation where someone shared, many people who are Medicaid don't know they're on Medicaid because they are enrolled through a local program. And so they might be part of a Cal Ultima, or they might be part of something else. And so they don't in their minds can make the connection of, oh, the federal government's going to cut Medicaid, that's not going to affect me. When in reality it is, but they don't understand that. And so the importance of educating people around what this is going to mean and who is really impacted, I think, is another area that we have been exploring. And then just pure advocacy, like funding, how do we provide resources to power building and advocacy groups? And I know that the endowment, and I'm relatively new here, by the way, I've been at the endowment for a little over 4 months, and that the endowment has sort of shifted from being a traditional health funder and health systems funder into more of a social determinant public health funder, or social determinants power building funder. And I think what we're realizing now is we can't ignore the fact that Medicaid, which is sort of the source that provides so many resources, is a target. And so we have to think about, we don't need to do a zero-sum game of like, we're not going to do social determinants of health and power building because we're going to do Medicaid. We have to think about how do we increase our spend in order to be able to do both, because both are important. And for me, opportunities to get out in the field and learn from folks that like yourselves that are on the ground about what are the things that we can be doing is one of the most important things that I'm doing right now. And I'm trying to have conversations across the state because then I can take those back to those meetings where the funders are talking about what are the needs, what are the opportunities for us that we can step into.
Thank you for that. Any other feedback on that question, Dr. Shaker or Dr. Burr?
I just to kind of tie into what both of you said, but also I'm a firm believer that we are truly greater than the sum of our individual parts. There are 4 very influential organizations that are sitting up here. We all work in different but similar spaces. We all serve the community in some capacity. I truly, truly believe, and those that have worked with me in other spaces know this, that I really do believe we are greater than the sum of the individual parts. And so when faced with a challenge such as this, and this, it's not to be taken lightly. We are looking at significant changes that are going to come that when they finally come through, whatever they are going to be, will have a very real impact in our communities. But that is that moment where we do choose to come together and figure out how we leverage each other, including the community and the advocacy that we're all talking about here, to really make sure our voices are heard and try to fill in those gaps as best as we possibly can, because that and therein lies our opportunity to move forward.
I hear that, loud and clear as I sit here representing a nonprofit, organization that has historically relied on private funding. I also understand that the private funding, even the endowments, billions, right? Or billion, billions, isn't going to make up for the losses that we may endure at the federal level. I served on the board of the California Wellness Foundation for 12 years, and oftentimes we were asked, to offset or supplant or backfill loss of government funding, and there is not enough money in philanthropy across the country to do that. And why it's so important for us to, again, collectively rise and fight against the devastated cuts that we're facing. If there was a time and if there was a hill, this is it. In terms for us to stand up and protect, again, what we've built over the past, several decades. And as I said earlier, some of us have spent all our lives working in this space. And although we may not be around to see the fruits of maybe this collective fruit, the fruits of this collective effort going forward, because the impact of these cuts are not going to be done in 4 years, right? These impacts are going to live with us for a very long time. I loved that there's so many young folks in the room, so many students, I want to not discourage individuals from not coming into the space because of what we're facing, but rather encourage you to join us and take the torch. So having said that, right, what opportunities do you foresee in your individual spaces to encourage that workforce to not walk away from the fight that we have before us? And I'll start with Dr. Roby.
Well, I think so. There's some threats here where the federal workforce is likely to be shrunken, and that is a goal of the Trump administration. And it seems very arbitrary, and it's not necessarily connected to any specific policy issue, but more like the administration does not believe in government, even though they're running government, and so they want to undermine government. So there are going to be opportunities because government still has a significant role to play, but it may be that instead of working for the federal government, people end up working in federal contractors and things like that. The other area I think there's opportunities is in the state in terms of leadership. So one thing I didn't mention in all the complexities around the federal budget, we also have a state budget. And Governor Newsom issued the state budget outline in January. It had a surplus. Receipts from taxes were better at the end of last year than expected. However, that surplus, just like the endowment surplus isn't big enough to offset all these federal changes, isn't possibly big enough to offset every federal reduction that we see. But I think it is important to get motivated at the state level around how do we play defense to an extent around the advances we made in health equity, in building insurance coverage and building the safety net. The concern I then have is the Trump administration is also interested in retaliation. And there are certain things that they have on their wish list around taxing university endowments and removing nonprofit status for certain types of organizations because they view those organizations as part of the liberal underpinnings of government and they want to dissolve those. And so if the state takes the lead on certain activities around health equity, you could have a fight in the federal level in the courts around is talking about health equity on a state website and prioritizing combating health disparities a free speech issue, or does it violate these new federal rules that would then take money away? So if the University of California is putting out reports on health equity issues and disparities, does the federal government then say that's illegal? And then we'll have these tests. And so I think in the next 3 to 4 years, it's important to be activated, as Isabel said, because these principles that we have around free speech and inquiry around disparities and understanding what helps people, what affects health status, what are social determinants, those could all be undermined by federal inquiry and retaliation. And to an extent, if you remember the first Trump administration, it was almost death by 1,000 cuts. It was tire everybody out until they just give up. And eventually, they got the individual mandate repealed. And they eventually got certain things they wanted. But I feel in the first Trump administration, there was a lot of learning done around how to navigate the federal bureaucracy. And that's what you're seeing right now, this big attempt to try to do everything at once very quickly because it is a big opportunity. And it could do lasting damage. So I think, it could be a scary place to be in, but at the same time, it's a very important place to be in because this is kind of a fight for our future, not just a fight over the next 4 years.
Brenda?
I'll add a couple of things to that. One is, part of the chaos they were creating in the first, how many days did you say it was? 40 days, is intentional, right? And to put all of us on our heels and to retract. And we've actually started to see it across society. And I keep telling people there's nothing we're doing that's illegal. We have to keep doing what we're doing, and we have to keep pushing and forcing them to get us to a point where someone declares at some point that something around racial equity or addressing health disparities is illegal. And I know that's scary, but if we cede to them the space and the power, then we're not going to have the opportunity to push forward. So that's one thing. The other thing is that I really want to build after Dr. Roby's point around the state and local, because our state and local players will have decisions based on what happens at the federal level to make here. And so we have to have that advocacy, not just at the national level, but at the state level, and then again at the local level. And how are we holding our policymakers accountable to continue to drive the things that are important in terms of health outcomes for this community? And oftentimes we've seen folks that get into these positions that then vote against the very same things that, you know, the community wants and needs. And so I think that there's another thing that we need to think about of, like, how do we hold those people that we elect at the local level and at the state level accountable for what it is that our communities want and need, more importantly. And then the other thing is that much of what we've accomplished since, you know, the 60s civil rights movement and building the safety net and creating these things that we are now seeing being dismantled, as Isabel said, it came from people collectively coming together and saying, this is what we want in the future of our country. And this is where I, you know, encourage young people to say, how do we stand up and get engaged and get involved? And oftentimes we think about it only in the context of our professional roles, but I would say all of you in this room should have sent texts and emails and calls to your elected officials, and get everybody in your family to do that, and get all of your friends to do that, because that's what folks who are elected need to be hearing from. And if we don't do that as individuals, we the people are not going to be served by those that are sitting right now in power.
Thank you. Dr. Schick?
I can easily echo everything that's been said about advocacy, about the role of the community. I'll give you a hypothetical example. If some federal sort of regulation comes down, state regulation, whatever, comes down and tells us, the healthcare agency, you need to shut down this program, whatever program that is. Pick any one of those programs that serves and delivers care and ensures that access of care to our underinsured, uninsured, lower income populations. If that program was to lose its funding based on federal or state requirements, we are going to turn around and go to the Board of Supervisors. And then we would go to the Board of Supervisors and say, look, this program's important. It serves this people. Help us keep this going. We answer the Board of Supervisors. The Board of Supervisors answers to you, to the community. So they need to hear from you that these things are important. So as much as, you know, there is, and I'm not exonerating the responsibility of any of the organizations that are seated up here, what I'm trying to say is we need to leverage all of our responsibilities in this, because as much as we can do, we also need the community to find the appropriate means to make sure that their voices are heard as well, whether that is text messaging, writing a letter, whatever else, to your representative, whether that is continuing to be informed and educated, or perhaps taking a public health career, whether that is working with the coalition, whatever it is, but to engage in that level and recognize that this is everybody's fight. This is everyone's responsibility, and this is everyone's fight. And Isabel, you mentioned the civil rights era, and that was a historic moment where we were able to change the path of this country at significant cost. I'm not going to minimize, all of what happened and all of that, but at significant cost, that community rose up and made sure that the country heard where it wanted to go. We still have a long way to go, but we're headed on that right path. But I bring that up because at that time, we didn't have social media, these devices in our hands, all of these things that make it literally the split second you can turn around and send a letter to your congressman. We need to utilize the tools that are out there at an organizational level as well as a community level to make sure that our voices truly are heard, and then rely on the systems that are built in so that we can continue to build and provide the care that we are all hoping to provide for those that deserve it and need it the most.
Thank you for sharing your thoughts on that. I was just reflecting that what happened during the civil rights movement benefited a lot of us in this room, maybe even before we were born, right? And so I think, again, I want to reiterate that we need to do the same for the next generation to come, because there's a lot at stake. So given that there's still, we haven't answered any questions, right? If you've noticed, we don't have the answers. There's still a lot of unpredictability, yet you're still here and you're representing a lot of community-based organizations and residents that are feeling the same way. So a question to all the panelists: how do we stay, what's your advice on staying resilient and productive in our space while we juggle everything that we don't know?
So I think coming to events like this is one. It can be very isolating. I know for me, if I sit in my office and I read the news or I watch what's happening on social media, I can spiral. And so being able to be in community with like-minded folks that you can talk about what you're facing, what you're dealing, and how people are managing all of the things that we are all managing, I think is an important part. One of the things that I have frequently been saying to folks is that in America, we used to have a lot of places where we would gather. And many of those have started to go away, which has broken apart our civic infrastructure. And the more that we can create these kinds of community spaces where we can bring people back together, I think is important. And think about it even more broadly than preaching to the choir. Really think about who are the unique partners that maybe have some shared aligned values or desires, and bring them into the conversation. I think the other thing that is important is self-care. I think it's really hard to be a leader at this particular moment, and being okay with the idea that you're not going to have all the answers. You're not going to solve everything, even with all the money that the endowment has. I can't fix everything, and so that makes me feel bad. Well, if that makes me feel bad and I'm not taking care of myself, then I'm not going to be good as I need to come back and try to figure out some answers. So I've made some intentional decisions about how do I think about self-care, and I encourage all of you to do that. And not only do it for yourself, but encourage it and model it for the people that work with you, because they're on the ground, on the front lines and struggling with this, and they will take cues from you.
Thank you. Dr. Ravi?
I don't have an answer for that. I guess I'll just follow Brenda's advice. But I will say, from a resilience perspective, I think many of you are in the community health center world, and that is the definition of a resilient movement, from the neighborhood health centers all the way to where you are now. You are also a very bipartisan, popular program that holds a lot of power in the state and in Washington, D.C. So if you think about the first Bush, or the last Bush administration, community health center funding went up quite significantly, even though there wasn't an attempt to expand insurance coverage and things like that. When you see the Trump budget, will probably try another time to remove funding for Planned Parenthood and put it into community health centers. So there are ways in which community health centers can strengthen their position as a community level provider that also acts as kind of a protecting force. And if community health centers are, supported at a bipartisan level in Congress, it's very hard for the president to then decide, oh, we don't want to pay those bills, because they will have Republicans and Democrats at their door asking for oversight hearings, et cetera. But also those community health centers, because they get a differential Medicaid rate, are also going to be able to advocate for protecting Medicaid and Medi-Cal in California. So I think community health centers have a lot of power in this discussion, because they're not just viewed as some sort of like safety net charity. They're viewed as like the cornerstone way that most Republican districts have access to healthcare for low-income people. And so if you look in red areas, they're very supportive of their community health center, because if they didn't have that, they would be, they'd just be reliant on emergency rooms, and a lot of resources would go away for their community. So I think preserving that structure will probably be a really important part of any administration. But I would use that power the best you can to ensure for increased funding in this, when everybody else's funding might be decreasing, and taking on an increasing role if we do face a situation where Medicaid and other programs are being reduced.
And can I just add to this, because he's triggering for me? For those of you who don't know, I moved to California after having been in Montana for almost 8 years, which was a very red and different state to work in. But what Dr. Roby said is exactly true. And so this is an example of where you could start to think about how do you build unlikely alliances with red areas, either in California or outside of California, because there is a vested interest. In many of these rural communities, Medicaid is what keeps the local hospital. It what keeps the local clinic. It's usually the largest employer. It has huge economic implications for these communities. And so this is where you start thinking like, who's out there that we need to be talking to? How do we make these broader coalitions that will actually get the attention of folks?
And I'll respond to that as well. And I would say absolutely correct. That's really what's kept the community clinic movement alive since the 60s until now, right? We have never been under this threat, this magnitude of a threat, because community health centers are the right choice in terms of prevention, right? We've reduced higher costs within the healthcare system. And we are in many areas the only game in town. In some cases, my counterparts up in Shasta, Redding, they're the only provider around for three hours, right? It takes folks 3 hours to get to where they're at. And yet those Republican congressmen and women are still voting for these cuts. And community health centers' main revenue depends on that enhanced PPS rate. So although we've been the, for lack of a better term, fair-haired child on both sides of the aisle for a very long time, again, this is the time when the cuts and the threats to that dismantling exists more real than it's ever been, at least in my, 25-year-plus career. But we're going to continue to advocate on that stance, right? That is why at the local level, regional associations of consortia, our statewide association, our national association, we're all fighting on that front, right? And using that example and all of the analysis, economic analysis, the fact that we're a workforce or economic engine within the communities that we represent. We employ, the doctors and all the support staff, administration, ancillary services. So the argument is there, but the assumption is that we can make a case with a sense of rationality, and right now that doesn't look, it doesn't look like we can do it in that way. But point well taken, and we'll continue to work on that. Did you want to have
A hard act to follow because, Brenda, I heard you mention self-care, which is generally my go-to advice towards the end, is to say, make sure you take care of yourself in this fight. I heard you say, surround yourself with the friends that kind of, have the same ideas, same shared thoughts and whatnot. And I also heard you say, think about building those unlikely alliances that you might need in this particular moment. And Dr. Roby, I very clearly heard you say, use your strengths, know your strengths to then advocate and leverage that to be able to advocate what needs to be done. So listening to all that, I'm thinking to Isabel's original question, how do you build resilience? And what I would add to that, sort of just to maybe complete the package, is to say, just continue to live by your values. You wouldn't be in this room. You really wouldn't have attended this. You wouldn't be in this room if you weren't in the field of sort of, being a servant leader, wanting to serve the public in some capacity, serve the people, serve the community. That's what brought you to this room. Whatever that value is that you live by, if it's justice, if it's integrity, if it's social, if it's equity, whatever that is, always keep that at the forefront. And some days may be harder than others, but just keep your mind and your eye on that end goal of we're going to get there. We keep referring back to the civil rights movement. They had that end goal of seeing a world where where the civil rights would be more equitable for all those that are around. And that, as they moved on and forward towards their end goal, keep your end goal in mind, keep your values at the forefront, and then just keep moving forward, with some days being harder than others. And on those days, self-care.
Well, thank you, all three of you, right? My staff is going to yell at me and say I went off script many, many times, but I think the conversation had to be organic. And so I've exhausted the potential questions that I have for my guests. We're going to turn it over to you all. Are there any questions that you'd like to make? Okay, so a lot of hands, and the mic's coming. over here.
Hello.
Yeah.
This has been a fascinating conversation. Thank you so much. Brenda, I had a question for you. You had mentioned reaching out to different stakeholders. How have your conversations been going with people that I think have a significant influence on this administration? And these are the business leaders in our community. So chambers, the CEOs, you mentioned workforce. It's not just the workforce of the people working in the community centers and the hospitals, but it's the people that work at Disneyland, the people that work at Amazon that would be directly impacted by these cuts. And I feel that the voices of Bob Iger, Jeff Bezos, these are the people that really have a lot of influence on this particular administration. What sort of advocacy has your group and really anybody's group been doing to educate these influential voices about what these impacts will have?
That's a really good question. And I think you're seeing the outsized role that those voices are having at this particular moment. And if I'm being totally honest, I don't think we're doing enough to educate those voices about the importance of what we're talking about today and the importance of community clinics and public health departments and federal government, right? That's in my conversations with business leaders, with chambers historically, I'm not talking about recently, there's always sort of their vested interests. And I think this is where we need to start figuring out where are the things where, maybe values wise, where we have different motivations, but there are alliances that we can move forward on and use that to help educate them. I'm meeting with the funders next week, and I'm going to take back this idea of can there be an intentional conversation with business leaders in California to try to push and counter the message that some of these voices have had. I think the other thing that we're trying to think about is, are there other ways to elevate alternative voices in this conversation, right? So we've pretty much done away with your traditional journalist media approaches that used to educate the public, right? We don't watch the news anymore. We probably don't subscribe to papers anymore. Journalism is kind of dying by the wayside. So as philanthropy, one of the things that we've been talking about is how do you make sure that you have that pivotal role that journalism has played in the American democracy experiment, and not cede to those folks that have created the social media spectrum that are driving the conversations. So I'm going to think of you when I'm at that meeting, and I raise that with other foundation leaders. So thank you.
Thank you. Any other? I saw a lot of hands. Okay.
Thank you. My question is for Brenda. I'm here as a board member for the Orange County Promotoras de Salud, also as a board member for the Community Hub de Santana. Precisely this week, we had a meeting and we had community members, mothers there, and it was very emotional to hear how this is impacting them. I was really impacted to see that many of the members that are part of committees, board meetings, and are community members, the promotoras. And the one thing that that they voice is that what they really need above right now this climate is they just want to know that they can call an attorney. And when I heard you say that the endowment is working on increasing legal capacity, it was like, wow, that's awesome. I know that there's been work already done around that previously, the previous administration for sure. But I wanted to learn if there is already a plan being put forward or how is the best approach for nonprofits to maybe propose or have some ideas how we can bring that as quick as possible to the community that's really needing that support and that alleviation. Thank you.
So there's investments in building this legal support at the federal level, at the state level, and at the local level from funders. So we are actually set up that same way too, right? Got national funders, state funders, and local funders. And so there are a number of funds that are being created to build up the capacity of legal services in your traditional, kind of who you would imagine being legal services. There's also conversations right now around how do we partner with the Bar Association, the California Bar Association, to try to leverage volunteer attorneys to come and help out nonprofits and the communities that they serve. I think if you have ideas, anything that came out of the conversation that you were at this week, to share them with me so that I can take them back as we start funneling more money into this. I think the thing that has been hard for me to watch is that there are disparate efforts that are happening. And I'm trying to say, can we help coordinate this a little bit? Because otherwise you end up with confusion, I think, in terms of what is available, how do you access it, and how do you take advantage of the dollars that are being put out there. I can tell you that legal services is at the top of everybody's list, which is good. But I'm hoping we can figure out a way to coordinate it so that it's a little bit easier to access on the other side. So any ideas you have around that, I'm going to be sticking around. So come talk to me.
Thank you. I had it right in the middle there. Okay.
We were talking about community coming out and helping and everybody doing, especially with the civil rights movement. Well, the voters really came out for Prop 35. And with the tax on that MCO, what I was really, Dr. Rubio, I was wondering if the federal government does make these cuts and these mandates, how much from a percentage point do you think maybe Prop 35 could mitigate some of that damage? And also, as an officer with Orange County, I was wondering how easy is a path to those funds to get them here to Orange County?
Sorry, can you repeat the second part of the question? Is it related to Prop 35?
Is there a clear path? Well, both. But is there a clear path to get those funds from Prop 35 down to Orange County?
Well, so to everybody who may not be aware, the Prop 35 was the provider tax initiative that was passed in the recent election. So our Medicaid program relies on a state share of Medicaid coming from to be matched by the federal government. And part of that is generated from taxing providers. And then you put up that state share and it allows you to draw down federal funds. And it allowed us to increase our typical primary care and some specialty visit rates to about 87.5% of the Medicare rate. So if you envision, 5 years ago, it was like $20 for an office visit if you're not getting care in FQHC, and now it's closer to 80. So the Trump administration and the federal government has been paying attention to this for a long time. So you can go back and look at Government Accountability Office reports on like provider taxes and health plan taxes, because there's concern at the federal level that it's being used to leverage federal money, but it's kind of funny money in a way. And so there probably would be an attempt in this budget reconciliation bill to cap the use of provider taxes or make a very strict threshold about how much you can take or what the method should be. Right now, it's basically done at the state level. So the state decides this is how we're going to structure the provider tax. They show it to CMS, and CMS project officers say, looks good. Like state operations makes the decision. And there's not a lot of scrutiny over the method, and different states have different methods. So I would assume that will lead to like a federal standard about how provider taxes would work, or an abolishment of provider taxes altogether. The understanding I have is that the provider tax, if hitting a threshold, the Republican idea is to allow them to continue to be used, because Republican states benefit just as much as liberal states around provider taxes. That it would probably save about $125 billion. So that's like over 10 years. So it's like what, a 3% cut? So not a 40% cut. So it's not a huge cut, but it would still undermine the fee schedule. Odds are what would happen is then if California couldn't leverage as much money from the provider tax, PCP rates would go back down a little bit because they wouldn't have that mechanism. In terms of bringing the money into Orange County, really the way it's structured is such that the fees come down to the managed care plan because we're in the Cal Optima system and there's a very small fee for service when people are like in a pending situation or emergency Medi-Cal. But generally, like the money's going to Cal Optima, that's then getting calculated into capitated rates to the providers or to a fee schedule that Cal Optima is paying that they might negotiate with each and every provider. And so it's very difficult to track how that money would work. But what would happen is the rate setting that the state engages in to decide how much to pay Cal Optima per member per month for a given year would then shrink by X percent if the provider tax wasn't holding it up. And then that entire amount would flow into CalOptima, but CalOptima doesn't have to spend that all on primary care or on providers. They could spend it on other things. So then you would need some oversight and conversation with the state around ensuring that CalOptima's primary care fees were adequate to satisfy the needs of California. And that would be a conversation with Department of Healthcare Services, not necessarily the federal government. So it's a very convoluted, like every time we have a fee schedule change, the fee for service fee schedule changes, but managed care plans don't necessarily pay on the fee schedule. They have negotiated rates with every provider to create network adequacy. So it's very difficult to track down how much PCPs actually get paid, how much specialists get paid. And it's different, just like it is in regular commercial insurance in terms of how it works.
Did that answer your question? Thank you. Go ahead.
Hi, thank you for having me today. My name is Melanie Ramirez, and I'm a third-year medical student at UCLA on the Prime track. Also want to shout out my peers at UC Irvine. We're part of a statewide coalition for medical students through Prime, and we're a specific track that wants to do medicine for underserved communities. I guess I share that to ask, I know with Tuesday's budget resolution, there is a lot of outrage, at least within my networks, but it feels like that outrage was very reactive after a decision had already been made. What advice do you have for students to be more proactive, before these decisions are finalized versus reactive? And then my second question is, a lot of us come from underserved backgrounds, first generation to college. And I know a lot of family and peers in Bakersfield and Tulare County who, if they had this information beforehand, they could have had a larger voice before some of these conversations were being made. And so I wonder, what advice do you have for students and young people to become more involved in advocacy that is both proactive and palatable for a larger population?
I'm happy to take that one.
Okay.
One, I would say first honor that outrage, because I think it's an appropriate outrage to feel that as you're starting to hear things that are going on, potentially going to happen, particularly if you're in an area and really focus on the underserved community. So honor and recognize that those are very real emotions, that and everything else that everybody is feeling in this room: frustration, fear, anxiety, just unpredictability, any of those words that are coming. So one, honor that. Number two, understand at a baseline that with this administration, there's going to be a lot of, for lack of a better word, unplanned surprises. You're just going to open up your phone and find out, oh my God, this happened. With no precedence, with no real planning, at least that we would, as the public, necessarily know about. So recognize that you may find yourself in that position quite a bit. To your ultimate question, what can medical students, what can you all do in this space? It's going to land in that category of get informed, get educated by whatever capacity you can. And largely, a lot of those advocacy groups that are out there, for instance, and I know this just because as a surgeon as a background, Southern California American College of Surgeons Advocacy Group has an entire medical student chapter that you can join and you can become informed on, be participant in, go up to, the state level and whether it's listen in or make or do your own advocacy for. Get involved in all of those chapters as much as you can, as well as try to get as informed and as educated as you can. Also leverage connections. We all have, capacity to inform, but as well as to connect you with people that might be able to better inform, better educate, get you the resources that you need. Let alone you have Dr. Roby from our public health school right here, who could perhaps give you far more information than any of the rest of us on the panel up here.
So I would say one organization to follow is Health Access California. So it used to be run by Anthony Wright, who's now the executive director of Families USA, but now it's still a very active advocacy organization that represents a coalition of consumer groups, labor unions, and other stakeholders. And they were scheduling town hall meetings in Valadel's district, Young Kim's district, Ken Calvert's district, like asking them, like, how are we going to vote on the budget resolution? And I think in all three cases, it was like an empty chair because none of the candidates showed up to the town hall. But there have been lots of there has been some outrage. So I would encourage you that just because you feel like you weren't able to be party to the outrage, it was happening. But I think what it takes is these issues always come up and you kind of need to be following them. And the policy idea wasn't come up with yesterday. It's been tested in Republican circles and we've been discussing them for the past decade. So we know what per capita caps would do because they've been proposed before and there are advocacy groups and researchers who have studied their impact. And so we know very quickly like how damaging they will be. And so there are organized coalitions that are already engaging. And so I think that outrage did show up this time around in not in a negative vote on the budget resolution, but in concessions by Mike Johnson to not use per capita caps and FMAP reductions in the final budget reconciliation bill. So I'm sure Valadao and Young Kim and Calvert and I think Senator Cassidy and others were saying behind the scenes, hey, I'm not going to vote yes on this budget resolution unless you guarantee me that you're not going to undermine my state's Medicaid program. And for optics, they wanted a victory. And so Mike Johnson was able to make a deal saying, oh, I'm not going to do this. And then they said, oh, well, you need to make that statement tomorrow after the budget resolution passes so I don't get attacked at my next town hall. So it's very much like, you know, telegraphed in a way. So there was an impact of that outrage. What remains to be seen is if people keep paying attention after the budget resolution. You see posts on social media now saying, oh, congratulations to the Republicans for getting rid of taxes on tips and not taxing Social Security. The budget resolution passed. And it's just noise because people don't understand the budget process or they're intentionally misleading people about, you know, a Trump victory. So I think staying up to date, kind of looking at like Kaiser Family Foundation, looking at California Endowment websites, kind of trying to keep up to date. I would definitely follow Health Access California so you know where the opportunities were, but you don't need to create something out of whole cloth unless it's going to be really effective. So you have National Medical Student Association, you have American Medical Student Association, you have other kind of groups that are built to engage in this type of work. However, the timing of their lobby days and those planned activities never works with the legislative calendar. So you need to know what the timeline is and when the opportunities are. So like if you talk to somebody on the Hill, it's always about must pass bills and deadlines for the budget passing and for the debt ceiling and for the continuing resolution to occur. And those are the very specific times in the year where your voice can be very important in shaping a policy decision. And the rest of the year, it's not because that decision has been made. So you can engage in issue advocacy all you want and go try to meet with congressional members and their staff members, engage in lobby day just to elevate, like Medicaid is important. Uninsured people face bad outcomes. We need better representation among people, among the physician workforce and other parts of the workforce. That issue advocacy is important, and that's what you're allowed to do as kind of a nonprofit and a student. But the timing is always unfortunate with those sorts of events. But you do have the ability to try to connect with staff members that you meet through that process and say, like, this bill that's coming up is a bad idea, or there are students that will be hurt in the following way, and give them actual examples. If you think about it for the most part, congressional members and their staff already have made up the decision about where they are on a specific issue. They are looking for cover when they make a vote. They aren't looking for reasoning. Like we don't do objective policy analysis and decide like this is better for this population or worse. It's really a political issue. And so congressional members on the right, they look at Heritage Foundation reports and they say, oh, this is a good thing and I'm going to vote for it at all costs. And I don't care what my constituents say, but they are looking for cover from people to say this is not going to negatively affect your constituent, and that's why you can vote yes on this issue. But they will trust any source that tells them the answer they're looking for. On the left, similar situation where they have trusted resources that they go to and they say, this is why I'm making the vote. So it's hard to break that cycle unless you have really good evidence or a new take or a new kind of motivated population to change their minds. But I do think, especially in the House, fear of losing the next election is an important aspect. And like, you know, I think Valadao and Kim won by 4 points maybe. I think Ken Calvert was like won by, or no, I think they won by 5 or 6, and Ken Calvert won by 4. Those are tight seats. You won't make a big difference in terms of the Senate, but you can certainly make a big difference on the House side. But then you need constituents of those members to be part of your group. And so you can, be viewed as a constituent rather than just somebody from the outside. And already we see this, people are saying, oh, the town halls were outside agitators through the Indivisible Foundation that were hired to participate in these town halls. And they're trying to undermine the idea that these are actually people who care about cutting Medicaid and the promises made by the administration. So I think it's a very fraught situation to be in terms of being politically activated. But I encourage you to keep trying and try to figure out what the points are where you can actually leverage your power, because a lot of times in the year you can't. And a lot of decisions have already been made up regardless of what you say. So you can't be dismayed by that. You just have to keep trying to an extent.
What I'd add to what my colleagues have said is we have to think the long game too. Project 2025 was thought about a long time ago. And so the push I give to communities and to people is to where do you need to be part of creating the vision of what this community should be like in 10 years, in 15 years, in 20 years, and what is it going to take to be able to move in that direction? And that takes organizing, and that takes power building. And so we're constantly on our heels because we're not thinking that long-term game. The other thing I'd encourage you to think about doing is not just health access, but there are a number of coalitions at the state and at the local level that are working on these issues, and we encourage you to explore those and get engaged. I'm happy to share with you some of the organizations we fund at the California Endowment that do this kind of work. And then I want to emphasize the voting, right? At the end of the day, it's really voting that will make a difference, especially in these races that are close. And I think young people have been disillusioned with voting, and so they're not coming out. And we need to, try to figure out how encourage young people to go out and vote, and to vote for people that are going to be more representative. That said, the political action committees in this country really dictate what happens many times in the way that people end up voting. Because as I said earlier, we might elect somebody who actually then turns around and votes in contradiction with what it is that the community who voted them in. So there's always that challenge. But I think we the people, have to go back to thinking about how do we drive change in this society. And it's really about power building, and it's about getting engaged, and it's about getting out and voting.
Thank you, Brenda. And I'd welcome you to join the coalition's advocacy effort so we can talk after the fact. Thank you. There's another question.
Okay. Hi. Thank you so much for this really great discussion. I'm the director of communications at a community health center, and I think it's a really difficult time right now to remain bipartisan, especially when you're talking about communications and how do we educate our patients, our community. So I heard you say, Brenda, that you guys are focusing on that. So I was wondering if any of you had any tips on, we're doing the best we can on remaining, focus on the facts, but sometimes these facts can be partisan right at this point in time. So I'm just wondering if you had any tips on how you're doing that, if that's how you're focusing on communicating to people in the community.
Yeah, I think facts are important, and I think we are fighting this counterculture of facts don't matter, and I think we can't cede ground on that either. Data and facts are important, and what we've been doing is really trying to focus on data and facts and putting that out there. If you look at any health disparity kind of data across any metric, you're going to actually see health disparities that hit particular communities that community health centers care about. And so bringing that up and showing that is important. The other thing that we're trying to do is do stories. Because you can fight with the facts, or you can create your alternative facts, but how do you counter some individual story? And I know that takes courage, right, in this particular moment to put a face or an individual out there. but stories are powerful. And I think something that we need to be thinking about. And then the other thing that we're trying to do is be unapologetic in our language. We've had a long conversation. It just came off a board meeting at the California Endowment. We talked about, are we not going to say the word diversity? Are we not going to talk about racial justice? And the answer is no, we're going to keep doing this because we have to, we must. It's a moral imperative at this particular moment for us to be able to do that. I think that's a conversation that each organization has to have in terms of of where their risk level is. We're all going to land differently, but when you have that conversation, like I did with my board, to say where are we, and they said we're all willing to take the risks, we're going to be high, then that empowers me and my staff to be able to move forward. So that's the other piece that I'd say is, how does your organization have that conversation about where is your risk tolerance so that you can feel a little bit more empowered about what you're saying and doing.
But do you worry about putting a target on the back, actually?
Yeah.
I know we're small, but.
Yeah. The question is, do I worry about putting a target on my back? Yes, and we must. Because I think that's part of what they're trying to do is to get us to cower. And we talked about leading with values. Like we need to do what have been core values of the California Endowment, no matter what. Will we be a target? Yes, we're on that list. And I know that I may get hauled into Congress. I might get investigated. But if I'm always leading with my values, then I feel confident that I am going to be able to withstand whatever. These are times where they're scary. And yes, we're going to be at risk. But if we go back on our values and our commitments, they've won.
There was a question over there, and then America.
Hello. Is it working?
Yes.
Hi, I'm a retired professor, and a couple items that I was struck with today. First of all, what Isabel said about sending messages to other people. Last week, I sent a message to about 40 or 50 friends, colleagues, family, advocating for LGBTQ and some of the issues related to DEI. And I just sent them to a whole bunch of people, and it doesn't take much time to do that. And you'd be amazed how those messages will hopefully take off from there. But this, the question that really disturbs me much, and I'll address this to Dr. Roby, is while Trump and Doge and his minions have literally used chainsaws to wipe out so many jobs and programs around the country, which certainly impact healthcare as we feel it here on the local level. But I'm also reading and hearing about the possibility of the executive branch taking over all the money that Congress is supposed to hold the purse strings to. Do you think there's a possibility that that may actually come about?
I mean, I don't think so, primarily because most of the members of the Supreme Court would not support that issue. So like, yes, it could happen, right? So we've already seen them try to use like a central Office of Personnel Management to make hiring and firing decisions, what they're not supposed to do. But it's kind of like, and it was like this with the last Trump administration, you know, they do things that border on illegality, and then they let the courts tell them what is right or wrong. The problem I see now is there's no guarantee that the administration will actually listen to court orders. And so what happens then? Then we're truly in a constitutional crisis, and you know, it'll depend on who the military reports to at that point. And there will be lots of moral issues that come up there. So I think like Justice Roberts and others probably do, even though they might be on the conservative side, probably still believe in the checks and balances of the Constitution and wouldn't allow that to happen. But it could take a year to work out. And then you have to decide whether the executive branch will actually live up to that. So like there have been temporary restraining orders that the administration has ignored at this point, and it's up to the judicial branch to enforce it. And President Trump knows that there's nobody at the judicial branch that can actually come enforce it. So, but then you end up with federal employees that know that if they follow court orders, they are protected. And there are lots of federal employees who are staying around to play defense and are not taking the fork in the road early resignation offer. They're not in their probationary period, so they can't be reduced that quickly. And so those folks will end up being kind of a line of defense. Like if I'm a project officer at HRSA and I have to send money out to my community health centers, and I'm being told by court order, you should send money out to those community health centers, you can still do it. You have authority as a federal employee to do that. And you may get in trouble, but like you can still stand behind that and then challenge that authority. But I think it will take a lot of people standing up to challenge authority if the president decides that the law doesn't matter anymore.
Can I tag on to that real quick? And just to add on to what Dr. Roby's saying, leadership, whether good or bad, however we choose to define either side, whatever's currently going on, whatever we consider good or bad leadership, requires followership. You have to have followers that support that leader to make that person a leader, whatever their trajectory is, again, good or bad. So in that vein, if the leader is not necessarily pursuing the path that is one that you find living up to your values, address the followership. Address the people that are there that are pushing those agendas along, or perhaps are the ones that are executing them or carrying them out. Because again, that's wherein the power lies with all of us, power building, capacity building, everything we've talked about here, calling your woman, congressmen, calling the senators, calling whoever to let them know if this is not working, this is not how this is supposed to be. Address the followership, because leaders can't lead unless there's followers that will continue to do what they want them to do.
America.
Good morning. My name is America Bracho. I'm the director of Latino Health Access. And thank you so much, Isabel and the coalition, for putting this together and for the panelists. I appreciate the thinking that you have been doing to respond to this. And we have talked a lot about policy and pushing policy, and I think that is a priority. I think there are concrete ideas in terms of what we can create, collective letters, and many things that can also help the nonprofit groups push the agenda, like having the ideas more clear that people can sign. How can they talk to their representatives? But I want to move a little bit into Brenda's comment about community power, because I think that sustainability goes beyond money only if you keep the trust and keep the work and keep the vision and keep the organizing and keep the long-term thinking. Otherwise, you might get actually a little bit of money for programs, but you won't exist. You know, at Latino Health Access, we have been, since December, working on first how to protect the community we serve. The community fear is real. I think that we need to protect the safe space where people can gather. We need to, and it's not about what we want to protect, it's about their perception that they are being protected. The perception that they are going to a place that is safe. And it's not only for our community, it's also about our teams. We work with promotores and people that are right there listening to everything that is happening and are seeing how people already are refusing programs or are thinking ideas that might not be helpful in terms of ongoing engagement. So we have deployed activities that might not require a lot of money. And I really want to invite people to think, what can we do with the people we serve? From teaching rights to actually organizing families for them to be the rapid response network in our communities. You know, we have the connection with the community, first-hand connection. So there is nothing that prevents us from doing that in our own strategic and in our own strategic way. So we need to train our community, train our teams. We need to talk with our team about this. We want our team to continue working. We want us to be strong. And for that, I appreciate all the ideas and thinking about the legal support for agencies to put together their policies, to understand what to do and what not to do, and not let ignorance paralyze you. we have to be brave in community, but not only in this type of community, but in the community out there of people that are the janitors and the gardeners and the people that are sustaining our economy and bringing food to our tables, that also need to be feel that they are represented and protected. So I think that appreciate also the idea of helping us get organized, helping change the narrative, not only the policy narrative, but the narrative about who we are. And I think that healthcare is super important, but when you're thinking who is helping, who are we helping collectively, are the people more impacted by inequities. So we cannot be afraid of saying that that's the people we are helping. So how do we change that narrative? How do we document abuses? How do we tell another story? And to be brave about it. Because the thing is that if we are not, then we stop being who we are, so we might as well erase ourselves from the map. And I think that as the federal government wants to make us tired, we have a lot of opportunities to make them tired too. So I think we need to learn how to make people tired, because this is not going to be forever. It's not going to be forever. It's not the first time this country faces a challenge, maybe not like this. It's not the first time that our organizations face challenges. So we need to regain our strength and our optimism and that only can be done not only in this community, but with the community that we serve.
Thank you, America. That's you took my closing remarks. Yeah. I definitely agree with you. I think we need to take the power back and use that power and influence that we know we have. We've seen it come out. We saw it during COVID, right? And so I think that we need to continue to be encouraged, because behind us are all the individuals that we are representing and serving. And we may have the voice that they don't have, but we need to continue to move forward in the fight in whatever tangible ways that we can. I think, we're out of time. I have some key takeaways, but again, I think America took them. So with that, right, I'm good. Thank you, America. She wasn't a planned speaker, but I appreciate it. Thank you so much for joining us. I appreciate all of you that stayed for this evaluation. Please fill out our evaluations for our feedback. There is a QR code in your tables that you can, yes. Oh, sure, yes.
Okay. Hi, my name is Maria. I just want to say thank you for having us, Cal State Fullerton students here at your presentation. It was very appreciative of all the knowledge that was provided here today. I work as an ICU nurse, and so I just wanted to know, I'm not very knowledgeable in the political part of all of this healthcare stuff. How, obviously with COVID and everything, we've experienced a reduction in the healthcare workforce already. And we serve the underserved all the time, homeless community, those in Medicaid, those are our patient population. So I wanted to know how these changes by the administration will affect us, direct providers, the bedside nurses, like what kind of changes should we expect in the future, and how can we help?
I think in general, healthcare spending is going to increase. Like, it's not going to go down. I think there are issues of burnout and turnover that are problematic now. I don't anticipate the Trump administration will allocate more money to like developing the workforce. I think we may see like level budgeting, which means it doesn't really change for things like Bureau of Health Professions, which runs the physicians in underserved areas programs. What I will say is there's a lot of attention on the philanthropic side. Well, one, not necessarily philanthropic, but Cal Optima is investing quite a bit on like the nursing workforce in Orange County. But also, I think recently Bill Conway announced like $1 billion campaign to build the nurse workforce nationwide. And so it gets a known issue that the American Nursing Association and other groups are already paying attention to. And the federal government has always played a backseat on the nursing side. Like there's no Medicare funding attached to nursing training. It's attached to graduate medical education on the physician side. But I do think some of those advancements on the philanthropic side will probably see changes on the nursing and other support staff side. But in this federal budget, I don't anticipate nursing will be a big issue. I think the AAMC representing medical colleges is focused a lot on the physician workforce and are championing those ideas about workforce shortages on the physician side in the future. So it may be that we'll see more of a move toward nurse practitioners and PAs filling in for physicians in certain sorts of practices and an attempt to do more team-based care. But I do think there will be some help on the horizon, not from the federal government, but from philanthropy around nursing workforce.
If I could tag on to that, I think at an administrative level, the hospitals, those that work in it, will find the indirect effects of if Medicaid and that funding is gone. A third of Orange County's population, roughly a third, is under a managed care plan, whether that's Kaiser or CalOptima, which provide the care for Orange County. So if the funding to that goes away, and roughly for any given hospital, if whatever 25, 30% of that population is under a managed care plan, such as CalOptima, and that funding starts to decrease, the ultimate amount of money that hospital is getting for caring for those patients will decrease. And that's where I think you would see the effects. Now, having said that, that's also where at the healthcare agency, largely a part of my role has been to bring in sort of my hospital background as well as now my public health background to try to break down these silos to see where we can start to leverage what I truly believe is the way to get to better health is to focus on the prevention side, not on the acute management of every issue that's going on in the hospital, though that is absolutely important. But to begin to see it help hospitals shift some of their work towards prevention, intervention, and community stuff that many of them are already doing, but perhaps more so for the long game that we've been talking about, that maybe right now that won't help, but in the future, you'll have hopefully healthier people. So your emergency rooms won't be as full, your ICUs won't be as full. But in the immediate foreseeable future, healthcare is going to take, healthcare costs are going to go up, people are going to get sicker, and that input is going to happen.
I'd like to close with one other thing. I think back to the question about how do we mobilize, how do we launch an advocacy strategy? Because I know that oftentimes when we come to events like this, you want the ask. What's the call to action? So what now? What do we do next? And I think, again, representing the Coalition of Orange County Community Health Centers, advocacy is how we started. Advocacy is how we'll continue to fight and address these issues, again, both at the local, state, and federal level. And oftentimes when we meet with our elected officials, they don't care to talk to us. We're the paid talking head, right? They want to hear from the doctors, they want to hear from the patients and the community. And we struggle to find patients that are willing to come with us and do that. I guarantee, I'm going to assume each and every one of you would want to do that. And it's important for us to also take folks that are from their constituency, right, within their district. When we met with Congresswoman Young Kim, she received us very well. She always meets with us, which goes back to the bipartisan support that community health centers have. But she really wanted to hear from the patients in her district. Before she took that vote last week, she did a poll in her district. And I know a few people that live in her district. So she really cared about the folks in her district. If we go in there with a group of us representing health and community health centers, and there's no one from her district there, it'll be a courteous meeting, and it'll be a pleasant meeting, but it won't lead to anything. So I invite you to, I know we have your information, I invite you to join us in those collective efforts, whether it's a postcard campaign, whether we're looking for a constituent from a particular district to go with us to these visits, I'd welcome you to join us in those efforts. And with that, I'm going to close. So thank you so much, everyone. Oh. And our next Coffee Connections event is June 6th. We don't have a location just yet and or the theme, but because of the ever-changing landscape. But please put that in your calendars for June 6th. Thank you.